So today, going to talk about a couple of things, but mostly revolving around difficulty interpreting some of the epidemiological studies that are out there, particularly around vaccination and vaccine efficacy and risk, and how some of the uncertainty that exists in the way these studies are conducted provides opportunity for folks to deliberately mislead and just muddy the water and make things confusing, but also these studies continue to contribute to our overall knowledge about the impact of the vaccines in transmission and impact. So if you remember a number of months ago, I think it was January or February, I talked about this one paper that looked at vaccination status and likelihood to get tested out of Australia. It was in preprint at the time. It's since been published in peer-reviewed journal, so it is actually now a legit part of the scientific literature if you are of that ilk. And so I think it's a good time to refresh our memory about that study as we talk about a couple, or at least one additional study that I'm going to discuss. If you remember, this was a study that looked at testing behavior and attitudes in Australians who had been vaccinated versus those who hadn't. And you can see they looked at over 1,500 Australian adults in a survey. And what they found is not necessarily surprising, but I think important to remember, is that folks who were vaccinated had a much higher likelihood of seeking out testing if they developed symptoms consistent with COVID. And not only were they more liable to predict that they would go get tested if they had symptoms, they had historically had higher rates of testing compared to those who didn't. So you can see that it was over twice as likely for somebody who'd been fully vaccinated. I say fully, obviously, with the 2 doses initial definition. So more than twice as likely that they would go out and seek testing if they became ill compared to folks who were unvaccinated. And that also reflected past behavior. As you can see, they were over twice as likely to have gone and sought testing in the past month. Ever been tested, they were also statistically significantly much more likely to have been tested. So what this tells you is that many of these studies that look at vaccine efficacy and rely on people presenting for testing to be counted as a case have this bias that's inherently introduced into the study. And especially if you're doing certain types of studies that are unrandomized and cohort studies, where again, it relies on people actually seeking out testing. So it relies on their attitudes and behavior. This is especially true in the test negative designs, which are mostly the methods that are used to measure vaccine effectiveness. And so what these authors did is then took those numbers and looked at how that would affect a theoretical vaccine efficacy study, looking at how the likelihood of testing would change vaccine effectiveness. And as you can see, that in the populations that are studied, again, not accounting for the fact that there's difference in test-seeking behavior between unvaccinated and vaccinated persons, you can see in many of these studies that there's actually a negative effectiveness measured for the vaccine. But what they show is when you take into account the difference in testing that they do in that calculation there, the true vaccine effectiveness is actually much higher than what's measured in the study. So in a theoretical study where your vaccine effectiveness is apparently negative 40%, right? That means the vaccine doesn't protect you; it actually predisposes you to infection. That the correlation in true measurement, if those populations had tested equally, would probably be a vaccine effectiveness of about 30%. So that's a huge swing right? You can see that, that's a 70% swing in vaccine effectiveness at that particular point. And you can see it diverges as your effectiveness goes down. But again, it's a huge difference in how effective a vaccine looks in these studies versus how effective the vaccine actually is. And if we look at another study that just recently came out, I think we can see how that actually works again in real life. So this is a study that was done in North Carolina, as you can see, by the State Department of Health and also folks out of UNC. And despite that handicap, I think it was a relatively well designed and executed study. Again, given the biases that we talked about. But if you look at this study, so they measured, and they were looking particularly at kids between the ages of 5 and 11, and they looked at North Carolina statewide databases for testing and for vaccination. And so essentially capturing all of the kids between 5 and 11 years old in North Carolina. So that's a little over 887,000 total children. And then they looked at infection based on laboratory testing. They looked at hospitalization and they looked at death. Now, according to the North Carolina State Surveillance System, out of those 887,000 children, about 193,000 had a SARS-CoV-2 infection between March 20th and June 3rd of 2022. So that equates to about 22% of children. So 22% of children in this study were infected with SARS-CoV-2, and about 31% had at least received one dose of the Pfizer vaccine, which is what they were measuring. Now, how many of you out there believe that only 22% of North Carolina's children between the age of 5 and 11 have been infected during the pandemic? Of course not, right? We know that that's a dramatic underestimate, and we know through a variety of studies and data sources, but this is one, I think, very good one, which is something we visited a number of times. But now the CDC has included a separate commercial laboratory database focusing specifically on kids to get a little more granular detail. We've talked about the other serosurveillance surveys in the CDC's network that show kids have a much higher rate of infection than adults. And this breaks it down again in age groups and kids. And you can see that among kids ages 5 to 11 in North Carolina have the highest seroprevalence of any pediatric population, 89% essentially by August, and it's roughly the same in June. So we'll just count it then. And again, the red arrow there points to the fact that this is a antibody test against nucleocapsid, which is only present in the virus. It is not present in the vaccine. So the only way you're going to have antibodies against SARS-CoV-2 nucleocapsid protein is if you've been infected with the virus. So these data seem to suggest, and very strongly, that about 89% of North Carolina children between the ages of 5 and 11 were infected by this past summer of 2022. So now if we go back and do the math in that study that we just looked at of vaccine effectiveness, they're estimating 193,000 kids, or 22%, but the real data suggests that it's probably 89% of children. So about 789 or 790,000 kids were actually infected. So that means there's about 596,000 children who are unaccounted for as actual cases of SARS-CoV-2 in that infection, right? And that will be vastly skewed towards unvaccinated kids, because as we saw from that Australia study and other studies that have looked at that test-seeking behavior, parents of kids who are not vaccinated are much less likely to take them in to be tested if they develop symptoms or if they're exposed. And so that almost 600,000 children who had COVID but were counted as negative in the study, again, are heavily skewed towards the unvaccinated. So now when we look at the results of the study, we see that phenomenon that the Australian study indicated would happen is that we see negative vaccine effectiveness, right? And every time one of these studies comes out and you have vaccine effectiveness ratio that's measured under zero, right? Negative effectiveness, you see the Twitterverse explodes with the anti-vaxxers saying, see, I told you, these vaccines actually predispose you to catch COVID. Well, that's just not true, right? It's an artifact of the study. And I think you can see that clearly here. So the reality is those numbers should be dramatically increased, again, because of that bias where unvaccinated kids are much less likely to seek testing. You can see that that effect even holds when you're looking at vaccinated children who were infected versus no prior history of infection. And I think that kind of reflects the fact that if you've already taken your kid to be tested once and you've had a documented infection, you're probably going to be more likely to take them to be tested again, even if you didn't get them vaccinated, right? So maybe you have, you believe COVID is real, you have more concern about COVID-19 than other parents may, but still you did the balance equation in your mind and you didn't think that vaccinating your kids was worth the risk. And so you still are likely to take them to get tested, but you haven't had them vaccinated, right? So I think a couple of things from these graphs, and this study again showed, I think, pretty definitively, that there's decent protection, not only against infection or against hospitalization, but these are against infection specifically. So does the vaccine protect you from getting infected? And there's, I think, a very strong indication that it does, and that protection lasts for many months. And even though there's indications that vaccine effectiveness wanes at a more rapid rate with more recent variants like Omicron, BA1, BA2, BA4, 5, now this only went up through BA2 12.1. This doesn't necessarily seem to say that's the case, at least in kids 5 to 11. I think that may differ as you get into higher age groups. But what this is showing is pretty good vaccine effectiveness. And that vaccine effectiveness is really more dependent on how recent your series of vaccination was compared to what variant you're being infected with. And I think that's also true in terms of prior infection. So this is, kids who were vaccinated relatively late. So in the in spring of 2022, and their vaccine effectiveness against Omicron, which was essentially BA2, BA2.12 infections at that point. And you can see looks not too bad, right? I mean, vaccine effectiveness still in the probably 60% and higher range to start with, and probably not much lower than that based on, again, the fact that those curves probably should be quite a bit higher. Then when you look at effectiveness against reinfection, so how much protection does prior infection give you? It looks somewhat similar, I would say, and you still see that significant fall off there over time as you do for vaccine. If you look at the right panel, so this is the risk of reinfection among vaccinated children, so kids who were vaccinated and infected. You can see that there seems to be a steeper drop off, but again, keep in mind that those curves are artificially steeper and at a lower vaccine effectiveness rate because of that bias that we discussed, and they should be quite a bit higher there. And finally, when you look at hospitalization, both prior vaccination and prior infection seem to still offer pretty good protectiveness or protection. So the takeaways that I would take from this study and the context of the data we saw in terms of what's the seroprevalence in those kids in North Carolina, et cetera, is that these non-randomized cohort and case control vaccine studies significantly underestimate vaccine effectiveness. And that's especially true for infection. Which is important, right? Because people are now saying, well, these vaccines don't protect you against getting infected. I think they do. And I think the data bear that out. And again, especially in kids, it seems to be a pretty strong protective efficacy, especially with recent vaccination. The other takeaways that I have is that vaccine clearly adds significant protection against infection and reinfection compared to non-vaccinated 5 to 11 year olds. And that lasts for many months. And again, that's supported by other data that we've seen. The best immunity you get is from vaccine plus prior infection. But if you don't have prior infection, getting vaccinated is much better than just relying on, getting a new infection and protection there. And again, in most places in the country now, every kid has been infected at least once, and many kids have been infected more than once. And that's reflected here, where you can see reinfections in those kids becoming more common with later variants, especially BA2, BA2.12. And again, recency of infection and vaccination is likely more important than which variant you got infected with, or potentially which vaccine booster you're getting. So timeliness and being closer to your last vaccination seems to be more important. Now, the next thing this leads me to is some of the recent data that's come out about vaccines out of Florida. And many of you may have seen this news release last week from the Florida State Surgeon General and discussing, apparently a study that was done by the Florida Department of Health, finding that there's an 84% increase in the relative incidence of cardiac-related death among males 18 to 39, blah, blah, blah. And therefore, the Florida Surgeon General had determined that the benefit of vaccination is likely outweighed by this abnormally high risk of cardiac-related death among men in this age group. A bizarre statement, and I think appropriately reflects what is apparently Florida's Department of Health slogan, which is, "It's a new day in public health," as you can see. It is a new day indeed. But let's look a little bit at this study and look at what this statement says and whether or not it's true. Now, you can look at a number of takedowns of the methods of this study and why statistically it's not a very good study. And I won't recreate those here, because I've provided a couple of links there, and with those you can kind of look at others who've done a much better job of deconstructing why the statistical approach of this study and the data gathering that they used is not certainly is not something that would meet scrutiny of other experts and how they counted. I will point out, when you go back up here and look, there are no authors listed on this study, which is a little unusual, and maybe I think a warning sign that maybe nobody wanted their name associated with this thing. But the more important thing is let's just look at the data they had, and let's suspend disbelief for a moment and say, well, okay, those other criticisms aside, what if their study actually was a relatively accurate measurement of the relative risk of cardiac deaths associated with the vaccine? How does that compare to the risk of dying from COVID in these age groups? And so a couple of things to point out. First of all, again, just to caveat the fact that this study has some significant problems in how they measured things. If you look at overall mortality in the age group 25 to 39, which is where they found specifically their most strong association, you can see that overall mortality was actually lower, by a significant amount, almost 20%, in the 25 to 39-year-old age group compared to people who were unvaccinated. So even though they found this potential association with cardiac deaths, their overall mortality was lower, and maybe not statistically significantly, but certainly wasn't higher. But there appeared to be a trend, certainly, of lower mortality in that group. So again, we'll put that aside, and now let's take them for their word and assume that even though we know there's significant flaws, that maybe just out of dumb luck, they stumbled on what is actually the true effect. And so you can see in that age group 25 to 39, during the risk period, right, which was the month after vaccination, which is where they would attribute cardiac deaths to the vaccine, there were 29 total deaths over the entire pandemic and vaccination in that age group. Now, if it's true that what they say is there's roughly a twofold increase in risk there, then you could say that roughly 20 of those 29 deaths would be attributable to the vaccine then. And so what we're saying is, if their data were actually true, then the vaccine would have been responsible for about 20 deaths of folks in that age group over the course of the pandemic. All right, so how does that compare with the risk of dying from COVID in that age group in Florida over the course of the pandemic? Well, it ain't even close, right? So between 25 and 34-year-olds, over 880 officially counted deaths in Florida due to COVID-19. And so if we're looking up to age 39, you got to add a few. And if you look there at that next age group, roughly 200, a little more than 200 in that age group each year within that 35 to 44 year age group have a COVID death if it's roughly equally distributed. So let's just kind of do a rough thumbnail estimate and say that would be about 1,000 deaths from COVID in the age group 25 to 39. That's pretty close to what those data say. So then you're saying that 20 attributable deaths to the vaccine in that age group are somehow overwhelmingly more important than the 1,000 deaths from SARS-CoV-2 in that age group. That math just doesn't seem to add up to me. So again, even if you think that the data in this study were correct and they accurately measured the increased risk of death from COVID or from the vaccine related to cardiac events, you still massively overwhelm that effect by the number of deaths they had with SARS-CoV-2 infection in that age group. And so if everyone in that age group had been fully vaccinated and up to date with the vaccine, based on what we know in other studies, that in this age group, there's probably greater than 90%, certainly greater than 80% vaccine effectiveness against mortality when people are up to date, then you can see it's no contest, right? You are much better off getting everybody vaccinated with the small risk then of cardiac deaths than you are leaving those people unvaccinated and again vulnerable to severe infection and death. The last thing I'll leave folks with is just kind of the latest update and trends in Europe and in East Asia, where things really are taking off with new variants. I think two countries really to watch, one from each of those areas, is Germany and Europe and Singapore and Asia. And you can see that this is actually hospitalization. So it's not cases, right? These are COVID hospitalizations that are just exploding over the last couple of weeks with these new variants that are part of the variant soup that we've talked about. It does appear that in Germany, of all the variant soup varieties, BQ.1.1 seems to be the most predominant, and it is, growing at a very rapid rate. But again, there are many others that are thrown into the mix. In Singapore, the XBB variant seems to be quite dominant, actually, and it is, predominantly the form of the virus that's circulating in Singapore. So we're seeing these new immune escape variants rearing their ugly heads in multiple places around the globe. And as I said, Europe generally predicts what's going to be happening in the US in a number of weeks. And so we can expect to see these new variants really starting to dramatically impact transmission rates and hospitalizations in the US. Soon, we're already seeing a pretty significant trend upwards. I don't think I included a slide, but a trend upwards in wastewater surveillance testing in the Northeast of the US, where over the past couple of weeks, rates have really jumped up considerably. So looks like the fall winter wave is going to be well underway soon. So that's all I got. Thanks.